Hello, everyone. We're going to talk about drugs for the treatment of fever and inflammation. So when we talk about fever is when, the body's temperature goes above its normal range. And we all have a normal range of a sort of a set point. And what my set point is might be different than someone else's set point. But we know that if we line up, a million people, there's kind of an average number. And you've already talked about this in your other courses, but fever itself is simply a natural defense mechanism for neutralizing foreign organisms. What constitutes a fever? Meaning, is it 100? Is it 100.2? Is it 100.9? Is really the topic for a different conversation. But what we're talking about for the purposes of this particular topic in pharmacology is we're talking about fever that is above normal and is serving a particular purpose for the body. So everyone's familiar with fever. We've probably all had one or know someone who's had one. And so there's just a few kind of concepts that we want to cover about this. So prolonged fever, we know high fever can become dangerous. And when we talk high fever, we're probably talking around, more than 100.2, 100.3. Now, in children, this can lead to seizures. And it's not that it can't in adults, it can as well. But in little brains, fever tends to come on quickly. Little kids are very good at adapting to their condition. And so body has some foreign invader or something that needs to be attacked. Little bodies can go from normal to really high fever really fast, and brains don't like that very much. And so sometimes we will see this in children, and it manifests as a seizure. It's really important to know that fever that causes seizures in children is not epilepsy. It's just a seizure due to the fever. Epilepsy is seizures that occur and we don't know the reason why. We don't know the stimulus for the seizure. So those two things are very different. In adults, high fever can break down body tissues, reduce mental capacity, lead to delirium or coma. In rare instances, an elevated body temp can be fatal. But in general, most people experience a fever for some period of time. It does what it's supposed to do, and we recover. So, if you take anything away from this lecture about treating fever, because it's so easy to want to give a pill for everything, right? It's really important to know that a fever is a sign of something going on in the body. It's sort of like pain. It's a warning signal. It says, hey, there's something going on here. The body needs to react to it. And so as a nurse, what is more important is to figure out what is causing the fever than treating the fever. And I know that sounds probably really counterintuitive, but treating fever is usually a comfort measure. Okay, but treating what is causing the fever can be a life-saving measure. If someone has an infection and they have a fever, and we as nurses say, oh, we can fix that, and we just go get Tylenol and administer that, but we don't address the infection that's causing the fever, the patient has the possibility of getting much more ill or, in some cases, actually dying. Now, the other thing is that there are some drugs that can actually cause or lead to a fever. And you don't need to necessarily, memorize these, but I just want to give you some examples because I think we often think of Tylenol or ibuprofen as an opportunity to just take care of a fever. But there are some drugs that actually lead to fever. So certain anti-infectives like penicillin, as they kill bacteria, pyrogens are released. And I've seen this happen many times in, again, oncology patients who have some underlying secondary infection going on, and we begin antibiotics, and their fever and their symptoms actually get worse periodically because all of those bacteria are opening up and lysing and releasing all of their nasty contents into the body. SSRIs can be associated with a fever that you will see in someone who has serotonin syndrome. So SSRIs are selective serotonin reuptake inhibitors. They're frequently used for the treatment of depression. And if they're taken in conjunction with other drugs or other conditions, can occasionally lead to serotonin syndrome, in which case there's too much serotonin, and this will raise the body's temperature. Some anesthetics can trigger fever, and you will see that people who work in the operating room train themselves for a condition called malignant hyperthermia, which usually once it happens, it's very difficult to reverse, and so can be fatal. And then cytotoxic drugs. And again, these are drugs that kill cells, right? Cyto is cell and toxic means that it's harmful. So chemotherapy is an example that really tend to dampen the immune response because in addition to killing cancer cells, we're probably also killing good, healthy immune cells that protect us from infection. And so when people are taking these drugs, they're more prone to having a fever. So how do we treat a fever? Remember, the key point is that you need to determine the underlying cause, right? So it doesn't mean that while we're determining the underlying cause, we can't go ahead and treat the fever. But again, I want to stress that this is not where we stop our thinking as nurses to say, oh yeah, they have a fever and I gave them some Tylenol. I want you to think, if they have a fever, what is that from? Oh, and by the way, this can be very uncomfortable, so I'm going to give them something for comfort. Common over-the-counter medications are usually the go-to meds to treat fever, things like ibuprofen, acetaminophen, aspirin. You can also do cold compresses on the forehead. That's more of a comfort measure. But you do have a lot of vessels and vasculature in your head. And so one of the reasons that putting a cold compress on your forehead, or in the case of this little picture, on your head in general, is that all that circulating blood up there is exposed to a cooling source, and that actually will make you feel better. If someone has a really high fever, you can do things like ice packs on their underarms and groin. You can put them on a cooling blanket. There are a number of other sort of ways to sort of deal with fever other than just medication. But medication in the form of these fever treaters, ibuprofen, acetaminophen, aspirin, are absolutely the way to go in conjunction with these other things. So let's talk about inflammation. Inflammation is a non-specific defense system of the body. Now, one thing that you need to know is that fever and inflammation often like to travel together, but not always. And there are many, many conditions where there's inflammation and no fever, like arthritis uh, and other kind of autoimmune type things. So I don't want you to always tie them together, but know that inflammation can also show up with a fever. So inflammation occurs in response to many different stimuli, including physical injury, exposure to toxic chemicals, exposure to extreme heat, invading microorganisms, and then autoimmune diseases and conditions. And that is not an exhaustive list, but probably the biggest causes. There's also two ways to think about inflammation: acute versus chronic. Acute is an immediate onset inflammation, a bee sting or something that swells up and looks really red and hot and painful. Versus chronic, which is ongoing inflammation, the type of thing that we tend to see more in like autoimmune disorders like lupus or arthritis. EG, by the way, means for example. So you'll see that frequently in these lectures. And when I say EG, I'm saying for example. So chemical mediators of inflammation, these are sort of the sources in our body that actually cause the inflammatory reaction. Okay, so these act again as alarms to notify the surrounding area of injury. So you should be familiar with these from your A&P courses. Histamine, right? We know that we take antihistamines. Leukotrienes. Leukotrienes are also inflammatory mediators, and we treat asthma by blocking leukotrienes. One mechanism that we can use for treating asthma. Bradykinin, complement, and prostaglandins. So the three that are in italices are three that we will talk about during this course, and we will talk about drugs that work in inhibiting these various mediators. So, how do you think anti-inflammatory drugs work to reduce inflammation? If you have these mediators, what kinds of drugs would you need in order to reduce inflammation? So let's look closer at one of these mediators. And it's a common one. It's histamine. And it might not be one that you think about a lot, but in the United States, a huge number of people take antihistamines. And they're taken for seasonal allergies and for skin conditions where there's itching and inflammation. So there's a number of medications that are used for treating histamine release. So histamine is, again, a chemical mediator that's stored within mast cells. And these cells line all kinds of epithelial membranes. For instance, they know for a fact that people who have really severe, like seasonal allergies, have a much higher number of mast cells in their nose and mouth and sinuses than people who don't. So that makes sense if you think about it, right? If mast cells release histamine and these people have more mast cells, that might explain why they have such severe allergies. But you have mast cells in your skin, your nasal mucosa, your bronchi of your lungs, your digestive tract, your blood vessels. You have them really throughout your body, but they tend to live in these places that tend to be the initial site of injury. So when histamine is released at the site of injury, it causes blood vessel dilation, which causes capillaries to become more permeable. Now, more permeable means that the connections in those capillaries, right, that in the blood vessel, in those little tiny vessels, become looser. And that's, that's good when we're talking about like oxygen exchange and nutrient exchange. But when we have an inflammatory reaction and those capillaries become more permeable, we can also get a lot of swelling, a lot of secretions, and becoming more permeable and becoming more dilated means that our blood pressure is going to drop and we're going to easily lose fluids from those vessels. So plasma, complement proteins, and phagocytes tend to enter into those capillaries to neutralize foreign agents. So this is really very protective, right? Our body's trying to protect us from an outside invader. And it unfortunately causes this kind of not so nice reaction. This is a perfect opportunity to talk about anaphylaxis. So anaphylaxis is a severe allergic reaction. It's usually an allergic reaction that causes life-threatening side effects. It's due to a rapid release of inflammatory mediators, often histamine, on a very large scale, and is responsible for this massive onslaught of symptoms, right? So a life-threatening allergic response can lead to death. If we don't get things turned around, this patient will eventually not be able to breathe. Their mouth, tongue, throat will swell up. Their lungs will fill with secretions and they will die. And you've probably heard stories of people who've died from things like bee stings or eating shrimp or having a peanut. And so we need to be really careful. Some people sort of have known propensity for anaphylaxis. And so we have to be aware of those folks. Really common causes that we see kind of on a day-to-day basis in like emergency departments around the United States are things like food. And again, shellfish is the number one offender in terms of foods that cause anaphylaxis. Insect stings, chemicals, even therapeutic drugs can cause anaphylaxis, but only if the person has an allergy to these substances. So I could take a medication and you could take a medication and I could be fine and you could have anaphylaxis or vice versa, okay? So whenever you are giving medications, that always needs to be in the back of your mind. Now, many medications are tolerated really well, which is why we sell them over the counter at pharmacies. You can go in and load up on a bunch of stuff, and that's because those have very low risk. But that doesn't mean that everyone can tolerate them. So you need to be careful. And you just need to always have that idea about anaphylaxis in the back of your head. So your patient all of a sudden begins to, start sniffling, coughing, saying they can't breathe. Perhaps their tongue feels funny, their mouth feels strange, their eyes are puffing up. Those are all signs that the patient is having a reaction to something, and you'll need to figure out what that is. Maybe you just gave a new drug. Maybe you just started a new antibiotic. All right. Examples of diseases and conditions that cause inflammation and may benefit from treatment are very long. I mean, it's way longer than this list. But I'm going to give you some kind of common ones that you will see. So, allergic rhinitis, which is basically just allergies, right? Runny nose, scratchy throat, itchy eyes. But rhinitis specifically refers to the nose. So, the annoying runny nose or congestion that you have with allergies. Anaphylaxis, obviously. Ankylosing spondylitis is a degenerative condition of the spine where the vertebrae are inflamed. Contact dermatitis, this can happen when, I don't know if anybody's allergic to nickel, but say the snap on your pants or maybe on a shirt causes, a dermatitis like in that exact shape on your skin. Crohn's disease, which is an inflammatory disease of the GI tract. Glomerulonephritis, which is a kidney inflammation. Hashimoto's thyroiditis, rheumatoid arthritis. Are you seeing any common things here in this list? Itis. Systemic lupus erythematosus. Now, erythema is in that name, and erythema is redness. Okay, so again, redness is associated with inflammation. Ulcerative colitis, and then respiratory disease. Now, things like, COPD and some other respiratory diseases may not be inflammatory in nature, meaning that's not their underlying, cause of the problem. But once, like in COPD, once there's destruction of those alveoli, then there becomes tissue damage, which allows for bacteria to invade, and now you have an inflammatory response there. So the biggest respiratory disease that probably responds well to anti-inflammatory treatment is asthma. So strategies to treat inflammation. Again, remember, inflammation is not in and of itself a disease. It might be part of a disease presentation, but it's more of a symptom. It's a condition that pops up. So there's two main classes of drugs that we use to treat inflammation. That doesn't mean that there's only two. There's just two main classes. So NSAIDs, right, non-steroidal anti-inflammatory drugs. These are good for mild to moderate pain, fever, inflammation, and they're preferred due to low side effects. Okay, so again, refer back to your pain lecture and information about the use of NSAIDs and their accompanying side effects. And then probably the most powerful drug we have for inflammation is corticosteroids. And corticosteroids, we make corticosteroids. Our bodies make corticosteroids. Our adrenal glands make them all the time. And it's how we deal with stress. And so our adrenal glands are constantly adjusting our bodies to accommodate stress. And we know that corticosteroids are powerful anti-inflammatories. However, there's a huge but here. But they can cause really significant short-term and long-term adverse effects. And so we save the use of corticosteroids really for severe cases of inflammation. There are numerous therapeutic applications. And so I say on here, you need to remember these, meaning that you really need to learn this class of medications. Even if you don't know all the specifics of a drug, if you know that it's what we call a corticosteroid, or sometimes we shorten that to steroid, it will immediately clue you into some of the side effects and some of the some of the bad that comes with the good of taking them for severe inflammation. It is able to suppress severe inflammation, but again, has many systemic side effects. So, they're reserved only for short-term use or treatment of severe disease. A great example of using corticosteroids in the short term for something that really does not respond well to things over the counter is if you have a really significant case of poison ivy. So if you get poison ivy or poison oak and you have like red, blistery, weepy, nasty, itchy, painful lesions from coming in contact with the oils in those plants, doing over-the-counter anti-inflammatories may provide some relief, but nothing like corticosteroids. Corticosteroids, couple doses for a few days, is going to wildly change how you feel and is going to vastly improve the condition. So again, that's a wonderful thing. We're glad we have it. We can use it for a few days. And using it for a few days is not nearly as detrimental to our health as it is when we use corticosteroids for a long period of time. And this is one of those drugs where you might say, gosh, why do we use them at all? It just seems like they're so dangerous. Well, when the risk, again, is significant, but the benefit outweighs the risk, then we need to do it. Some people will die from inflammatory diseases like severe Crohn's disease, or other, severe inflammatory conditions. And so the trade-off is, yeah, we can use steroids to control that disease, but we also have to be aware of the side effects or the sequelae from doing that. Corticosteroids, again, are these hormones, and they're released by the adrenal cortex. And if you don't remember where the adrenal cortex is, please go look it up. Google it, go to your A&P book. But it's basically this little pyramid-shaped gland that sits on top of your kidneys. There's one on each kidney, okay? And so it's those glands that release corticosteroids. Now, I've already told you that steroids can be used to treat asthma, arthritis. They can even be used to treat cancer because of their effect on the immune system. They can also be used to treat people who have a corticosteroid deficiency. Some people actually don't have enough steroids. These people have what's called Addison's disease. And so if you don't make enough of your own corticosteroids, your adrenal glands don't make them for some reason, or they go into crisis, then we're not able to adapt to our environment. Meaning, for instance, we would not be able to mount that fight or flight response because corticosteroids are part of that. We would have trouble. Yeah, we would have trouble in a stressful situation physiologically. Okay. So also, corticosteroids inhibit the biosynthesis of prostaglandins. Ah, surprise! Does that sound familiar? Because it inhibits prostaglandins, again, it treats inflammation, but there are multiple mechanisms that corticosteroids affect that end up leading to reduction of inflammation. The only thing about corticosteroids is because they don't just affect one area, like just prostaglandins, they can be really powerful immune system suppressors. And so, again, that is another big side effect, or can lead to many other side effects. But corticosteroids are really the most powerful anti-inflammatory that we have. We do now have a number of monoclonal antibodies, which also can work well for inflammation. And the great thing about monoclonal antibodies is they are targeted to a particular receptor or cell that is tending to cause the inflammation. There are tons of ads on TV now for these monoclonal antibodies, but I just want to make sure that you don't confuse monoclonal antibodies with corticosteroids, because corticosteroids, they are like the machine gun of inflammation. If you have it anywhere in your body and you're taking corticosteroids systemically, you're getting them parenteral or enterally, and they're going throughout your whole body, you're going to get knockout of inflammation everywhere versus something like a monoclonal antibody, which is very targeted. That's more like the handgun, right? That targets a specific cell. You'll hear me use that analogy again when we get to antibiotics. So corticosteroids. So, yep, they're amazing. They're powerful. They do great work when it comes to inflammation. And actually, fun fact, corticosteroids are also amazingly good at helping with chemotherapy-induced nausea and vomiting. Now, do we just take people who are immunocompromised and give them a big shot of steroids just to help their nausea and vomiting? We do, but we don't do it very often. We do it very carefully. Again, risks versus benefits. We're always looking at that. So let's look at these side effects that make us shy away from using corticosteroids as our solution for all inflammation. So things like hyperglycemia, mood changes, and this can be significant. We'll talk about this a little bit more in class, but with really high doses of corticosteroids, you can get almost a mania. Cataracts, peptic ulcers, electrolyte imbalances, specifically hypocalcemia is one that you can get. Osteoporosis. It can mask the signs and symptoms of infection. It can cause growth retardation in children. Long-term use can result in muscle mass loss. Striae, which are stretch marks, and frequently on the abdomen, the legs, the arms, due to thinning of the skin. Fat redistribution. So you'll see like moon face and buffalo hump, and we'll talk about those more in class. Excessive hair growth, meaning that someone who's on high doses of steroids may have like kind of a more, even in women, like kind of a more furry face, like that fine hair that grows on your face can become thicker and more pronounced, like shoulders, back, arms can show excessive hair growth. So overtreatment with steroids can cause Cushing's syndrome. When I say overtreatment, I don't want to say that people who develop Cushing's syndrome from getting steroids have been treated improperly, because sometimes, again, we're going to take the trade-off of having a little Cushing's syndrome so that we can control some severe inflammation that would be otherwise probably life-threatening. Okay, but if you see somebody with Cushing's syndrome, they have all these side effects that are listed over here. Cushing's syndrome is just some doctor's name for having having the effects of high corticosteroid levels. Okay. You're not going to see Cushing's syndrome with 5 days of treatment for poison ivy. You're going to see Cushing's syndrome in someone who's taking corticosteroids for control of their ulcerative colitis for 6 months. Okay. Adrenal glands do get used to outside corticosteroid levels that we put in. And so what happens is your adrenal glands are like, we have plenty of steroids here. I don't need to make more. steroids, and the adrenal glands become a little less active. And so if all of a sudden you stop giving a patient steroids who's been on them for a long period of time, you just stop those abruptly, they will go into adrenal crisis. So you need to taper patients off of steroids. And tapering means lowering their dose a little bit at a time over time. So maybe they're going to take 40 milligrams for a week, and then they're going to go down to 30 milligrams for a week, and then they're going to go to 20 milligrams for a week, and then 10, and so on. Okay? And that is to give the adrenal glands time to rev back up, to kick back into gear, and to make more corticosteroids. So there are other drugs that treat inflammation as well, and you don't need to learn these particular drugs that I have listed, but I want you to be aware of them. I want you to know that it's not just NSAIDs and steroids. I want you to know that there are selective COX inhibitors. Now, NSAIDs are COX inhibitors, but they are non-selective COX inhibitors, meaning that they inhibit COX-1 and COX-2. Selective COX inhibitors only inhibit COX-2, which is sort of the negative thing that happens as a result of prostaglandins. Sulfasalazine is an old drug, falls in the same family actually as aspirin, and it's used a lot for bowel inflammation, so ulcerative colitis, Crohn's disease. Allopurinol is the drug in and of itself is not anti-inflammatory, but it reduces uric acid, which uric acid buildup is what causes gout and inflammation of joints. So it's anti-inflammatory, but kind of in an indirect way. And then monoclonal antibodies, which I mentioned before, which are often specific to a specific type of inflammatory marker, and they are expensive. And like I said, you will see them advertised all over. If you watch any television or even streaming service that has commercials, you'll see this. And maybe I see a lot of them because of my age and they've targeted me, but lots of things for arthritis, psoriasis, lots of autoimmune inflammatory diseases. Last but not least, I want us to always be thinking about complementary and alternative medicine. And because people do use these things. And probably the big one out there is fish oils. So you'll see this, fish oil for people who have maybe heart disease or atherosclerosis. They inhibit the conversion of arachidonic acid to pro-inflammatory prostaglandins. So again, it's a prostaglandin inhibitor. Fish oils reduce triglycerides. And then, if you want to have some fun, you might look up, do they improve cognitive function in Alzheimer's patients? And are there any interactions between NSAIDs and fish oils? Because a patient may be prescribed NSAIDs by their physician, and then they say, "Oh, but I read about fish oil, or I heard about it on the internet," and they go ahead and buy those just over the counter. It's a supplement. So something that you need to be aware of: these fish oils have DHA and EHA, which are compounds in them that are these omega-3 fatty acids. And so ask around, ask your parents, ask family members and other adults in your life if they take fish oils, and I bet you'll be surprised to see how many people do. All right, that does it for drugs for fever and inflammation.